All right, so day 3 of this second part of Fix. I know some of you were excited to jump back in this, but really this is just an extension of endo, right? So, got you there. So we're going to talk about post and core, which requires talking about canals and stuff. So I know you guys are over it after 2 weeks of endo, but we got to revisit this topic just a bit. All right, so yesterday we talked about this idea that, sometimes we have an extensively damaged tooth, and one way in which we can build that tooth back up is by using the existing walls of that crown, or the canal space in the walls, to hold in some sort of buildup material. So in our case yesterday, we used amalgam. And as long as we have that mechanical retention at that macro level with opposing walls, then it was able to be held in. Okay? Sometimes we don't always get that. Sometimes the tooth is so broken down that the walls itself of the tooth won't hold any buildup material in place. So the solution that we come up with is we want to put a post into the canal space. All right? So a post should be considered only when other forms of retention are inadequate. So if you go back to yesterday, we can just visually see this amalgam. It doesn't really have a path of dislodgement. It's kind of just locked in there. So this wouldn't require a post. Whereas an example here, and this is a stone cast of the teeth, but you can see how much more broken down this tooth is. And your opposing walls aren't really sufficient to hold that in. So there's no hard and fast rule of like how many walls or how tall they need to be. I think this is part of why they make you take the PAT before you get in here, is that you kind of want to visualize what that buildup would look like, and you just kind of pretend that that thing is rolling off in all different directions. Is there a direction in which that could potentially just roll off in? And I would say in that case, yeah, right? And as you see more and more cases, you'll find more and more instances of, oh, this buildup just fell out. So if you ask any practicing dentist and you ask them, oh, when you take off an existing crown, right, section it just like you guys did yesterday, how many times have you had the buildup just stuck on the inside of your crown? And that happens quite frequently. Okay, so that's examples of where the buildup wasn't retained well within the preparation. Okay, so the more of those you see, then in your own head as you evaluate preps, because you could see the prep, what's left of it, and you say, oh, this didn't hold that buildup very well. I know not to prep it like that. So it just comes with more and more clinical experience that you'll kind of find what's going to work, what's not going to work, and when you want to put like a little groove or extend deeper into the canal, or maybe even use a post. Okay, but big picture, if it can't retain the buildup, then you got to find some other way to hold that in. All right. So I know yesterday we talked a lot about, or on Monday, like non-retentive preps, right? So we kind of set that as sort of, oh, we don't need to do it the traditional way. We could just bond composite to this tooth. We don't need kind of this retention. So why doesn't that concept apply to this crown buildup example? Why couldn't you say, well, I don't really need that much opposing walls. Composite is great to bond to, or bond with. Let me just throw some composite in there, right? Etch, bond the tooth, throw some composite, light cure. Why wouldn't that work? So the key there is the amount of enamel that we have, right? So on Monday, when we showed all the examples of your inlay, onlay, what did we emphasize? We said, well, look at how much enamel is around there, right? And we said, you don't need to drop your margins so gingivally, because if you leave it a little bit higher, you get a greater ring of enamel. By the time you prep a crown, all your enamel is removed. So now we don't have that good bond to enamel. We're now bonding to a weaker dental substrate, right? Dentin, yes, we would say it bonds, it has this hybrid layer, but definitely not as strong as enamel bonding. So it's not something I would solely rely on when you don't have some resistance or tension form from your walls, okay? So yeah, it's going to hold better than just amalgam, which is pure mechanical retention. But the fact that you're bonding to dentin, not enamel, kind of reduces the bond strength there, okay? All right, so the purpose of the core, or sorry, the posts, is just to retain the core buildup. There is this thought that, oh, sometimes if you put a post in there, it'll reinforce the tooth. Meaning, right, the tooth has now been hollowed out. You took a file and just created space there. Why don't we put something in that's stronger than gutta percha? Maybe it'll make that tooth stronger. Well, that's been disproven. In fact, when you put a post in, it actually is at higher risk for that tooth to fracture because that post acts like a lever arm, okay? So really the purpose of putting a post in is to just help you retain the core buildup, okay? All right, so there's differing posts that we can place. The first one I'm going to start out talking about is a custom-made, or what we call a cast post core. Okay. So the first thing you'll do is to drill this post space. So you want, and we'll talk about the length and the diameter of the post space, but basically you want to make room for it in your canal, okay? So conceptually, that's sort of the first step. Make room for post. And what you're going to do is, and we'll show you a little video of this, but you're going to put a plastic post into your canal, and then you're going to start to add this auto-polymerizing or chemically cured acrylic. So that red material there, that used to be powder and liquid, your monomer polymer, right? And you slowly add to it so it'll flow into that canal space, polymerize, and you slowly build it up. And eventually it'll polymerize and get hard. Once it hardens, then you'll take your burr and then prep it so it looks like a crown. So that middle picture is what that looks like. So in the middle of that is a plastic post. Surrounding it is your acrylic that is able to be burned out. So if you look at the picture on the right, that looks like a gold picture, or the same kind of contour as the middle picture, except that it's gold. So we all know how this works, right? How do you turn something from, in our case it was wax, or in the crown case it was wax, but in this case it's going to be acrylic. How do you turn something from that acrylic to gold? It's going to be the same laboratory method that you did when you casted a gold crown. Good question. That sets us up for this slide. Oh. All right. And no, we didn't plan that. Okay, so there's retention and resistance form, right? How do we understand the difference? So let's clarify. Yeah, Emily?
Retention form is along the path of...
Right. So retention is along the path of dislodgement. Resistance form is any other path, right? So I would say that our retention form just comes from the fact that you have this long post that engages the walls of your canal space. So very similar to your crown prep in the axial wall height. Just the mere contact of the tight fit of that helps things from being withdrawn. Just like you have, perfect, you got this sleeve on this coffee cup, right? This will stay on, as you can see, just by some sort of close adaptation to it, okay? So retention form. Resistance form is going to prevent the rotational aspect. So what you do is you prep sort of a little notch into your canal space so that when you can index the post when you put it in, right? So you see this little notch, you prep that feature into it, and you can see that there. So that kind of acts as a key to make sure you're lined up correctly. Okay, so this is kind of what it looks like, right? So again, if you kind of just imagine, if we change this to black and white, you'd see that the picture on the right just looks like a regular crown prep, and you know what to do with that. You would pack cord, make compression, and make a crown. Yes?
I just don't exactly understand how we get the acrylic down the canal.
So the acrylic is going to be like liquidy, so it's going to flow.
And
Yeah.
is it or decide what drill
Mm-hmm.
we're going to use? So does it flow down the drill, which is in the canal?
No, you drill the space, so you got a hole
And then
the size of the...
is dripping into that?
Right.
Okay.
So it's going to flow down in there. So as you add powder and liquid, right, the thing is kind of liquidy. I don't know.
Yep.
Yeah. Okay. And then if you went back and looked at the video, that yellow post, it's got little ridges in it, so it has some mechanical retention for that acrylic to stick to. That and the fact that it just encases it too helps. Okay. Right, so then that gets luted into the canal, so we just need a luting agent to fit those two things together because it's pretty well adapted to the walls. That should stay in okay, right? So again, sometimes when you take off crowns, this whole post sometimes and core comes out in the crown. Sometimes your connection of the cement from the crown to the core is so strong that your weak link becomes the cement layer between your post and then your tooth. Okay, so at some point something gives. All right, so that's what a radiograph of that would look like. Cast post acts to provide a foundation for adequate tension resistance form of a crown. Any questions on that? So that's one of the two exercises we're going to do today. Pick an anterior tooth to do that exercise. You're going to cut it down sort of arbitrarily. You want at least 2 millimeters of axial wall height in your simulation. And then you're going to first prep it down with a margin. And then you're going to go through all the steps, putting in the plastic post, building up with acrylic, prepping it down. Okay? And the key there is make sure that canal space is obviously divergent. If you have something that's convergent, and if you have any, most of your canal space shouldn't be undercut because you've done a good job, removing the roof of the chamber and all that. But you just want to ensure that there is some path of withdrawal because when that acrylic polymerizes, it hardens, it won't be able to flex over those undercuts. Okay? Make sure you lubricate that tooth. Okay? Because somebody here today is going to have theirs locked in. We're going to go back to this moment, and they're going to come back and say, "You jinxed me." And I did. So somebody's going to do it. The question is who? Probably the one not paying attention right now. All right. Faculty will make our bets later. No, just kidding. We don't do that to you guys. Okay. So we have different types of posts. Okay. So that was one type. One of the ones, and I'll be honest, the cast post and core we don't do very much anymore. And part of the reason is such a big, heavy post. One, the expense, the time that it takes to do it, and then we found other post systems that work kind of just as well. Yes. We have Surgilube, yeah, so we'll provide you with that. And we found that the post, the cast post, since it's so well adapted all the way down the canal, sometimes it acts sort of as a wedge and actually has a propensity to kind of split kind of the root because it's so big and bulky. And that gets into this discussion that we used to do these active posts, and sometimes you'll see some of these in your patients that had root canals done prior, that, this thing just looks like a tooth destroyer, right? So the idea is, yes, we want good retention of that post, so we put some threads in there and we screw it into place. But what do you think it does to the structural integrity of that canal space and that dentin? It kind of weakens it, right? So that's a really aggressive post that we know we don't really, it does sort of more harm than good. So yes, you would say there's plenty of retention, but it puts the tooth at risk for fracture because it just puts a lot of stress points at the edges of those threads. Okay, so threads engage the dentin, thought to be the best retention method. Materials metal. Risks that engagement may lead to fractures, therefore not indicated anymore. Question? Carefully, yeah. I've never had to remove one. Most of the time, the tooth gets removed because it's fractured. I think. Yeah, I don't know how endodontists do it. Maybe we can ask them. Yeah. And then just kind of reverse it out. Yeah. Shake it loose, yeah. Yeah, hopefully you don't have to remove too many of those in your day. I think we're seeing much less of these okay? But they're still around there. All right, let's compare that with a parallel-sided post. So this engages, more passively engages the walls, meaning you're just relying on sort of the adaptation to that. And if you think about sort of your post space, or your canal space, yeah, you're drilling with a parallel-sided drill, but just the natural flare of the canal space, right, it's wider at the top than it is at the bottom. So when you use these parallel-sided posts, really just the bottom half of the post engages the walls. So I don't want you guys to over-widen it just for the sake of the whole post being able to touch a wall somewhere, okay? So you don't need the whole thing, because at some point you want to limit the amount of tooth that you remove. So I want you to really value tooth structure, especially as you get down apically, because what happens to the amount of tooth as you go further down? Everything narrows down, right? So generally where things are going to break is at the tip of your post. That's where you end up splitting the root. So you want to try to preserve as much width of tooth there, so you don't want to over kind of drill that post space. So don't need to widen it to the widest part at the top. Just look at the bottom and then kind of see how much thickness there is. And you use this, you determine this using radiographs mostly. So there's a little slide on that and how to measure that. Okay. Then we have different materials. Obviously, you have a metal material. So this is an example of a metal post, which is what you guys are going to do today. So your second exercise is essentially just doing a posterior tooth where you drill a post space, and then we're going to insert a metal post into it. So you can see at the top of this metal post, it's got these big circles, right? So since this scenario, the post and then the build-up material is two different materials, we need to somehow connect that build-up material to the post. So we're going to use just macro or mechanical retention. So we have these undercuts built into these posts, and then that composite's going to polymerize around it and just kind of lock on. Okay? Which means you got to cut the post to the right length. So when you cut this post, guess which side you're going to cut if it's too long? The part with the circles at the top or the bottom? The bottom, right? So you want that circle part to be, you know, basically at the level of what your build-up's going to be. And you also need to consider what your crown prep reduction is going to be, right? Because you don't want that circle part to be at that, you know, 1.5 millimeters of your proposed occlusal surface or incisal edge, because you're going to prep that away during your crown prep. So you kind of want to imagine how tall my crown prep is going to be. That circle should be within that parameter. Okay? All right. So the downside of this is it's metal, so you got to, you know, sometimes the graying shows through. Here they show an example of just blocking out that color with a more opaque composite. But sometimes in the interior area, that metal will still shine through. And it'll be a little darker. It just looks a little less lifelike when you put that final crown on. So these get luted into place. Obviously, there's no bond to the metal. And then the core is mechanically retained onto the posts via these retentive features. Then we have a fiber post, which you'll find us using down in the clinic most often. And principally, it kind of follows the same idea, except that it's made of resin and fiber, okay, glass fiber. So the advantage of that is it looks more clear, so aesthetically it looks better, and then you can also bond this, adhesively bond this into place. So you can use some sort of resin cement to get that down and adhere to the dentin structure, okay? So excellent biocompatibility, mechanical properties similar to dentin. So this is important in the sense that if you think about when you load your tooth, there's always a little bit of flexure within there, right? So if you were to compare a metal post with the dentin structure and you look at the flexural strength, they don't really match each other, right? Metal has a hard time bending. But if you had a post that more similarly matched the mechanical properties of the dentin, obviously that, in theory, should be better. And that's what we find is that the little bit that the dentin flexes, the fiber posts will move more similarly to the dentin than a metal post would. Okay, so not only the mechanics of it, but also the color have sort of improved, so we use less and less of these metal posts or even these cast posts. Okay? All right, let's finish up with post length and post diameter. So studies have shown that the post length increases, or as post length increases, obviously the retention does. But there's it's not a linear relationship. So at some point there's a limit to how far down you want to go. Obviously you don't want to put the post all the way down to the apex, right? Because as you go down, the root narrows down, and then you start compromising the integrity of the actual tooth. You don't want that to split. So, and you guys can see how fragile some of this tooth structure is, right? As you guys did endo, how many of you guys had either a cusp tip flake off or a root break? Anybody experience that, right? Okay. So obviously there's some limit to that tooth structure. So there's a balance, right? You need enough to retain the post, but you don't want to go too deep. So we have these kind of clinical guidelines that aren't hard and fast rules, but approximately 2/3 of the root. At minimum, you want that 5 millimeters of gutta percha. And I'll need to go back to your endo lectures. Did Dr. Lebo talk about this and give you guys a figure? Okay. I'll have to look at it because I know he talked about this at some point one of these years, and there are differing numbers. So we'll confirm with that just so you guys don't get confused. We have the same criteria. But for now, we'll say 5 millimeters apical gutta percha to form a seal. You said 5? Okay, good. Because last year I said 4, so I think I got yelled at. Because Lebo always wins. And then obviously the other consideration is the root's curve. Not everything's straight. So again, these rules are not hard and fast. You're not going to, put a post through a curved area just to get your 2/3 of length, right? So at some point you say stop. Okay. So do you guys have radiographs of your teeth that you did root canals on? Okay. So obviously you want, when you select your poster tooth, you'll have that same radiograph, and we can go through and measure kind of what an appropriate length is on your canal. Okay. So we'll shoot for 2/3 unless there's some sort of curve. For your maxillary molars, let's say, you want to pick sort of the biggest, straightest canal, right? You want to avoid the one that curves. So generally you'll pick your palatal canal. For your mandibular tooth, we can look at your radiographs and see which is the most appropriate canal to put it in. All right? How about post width? Obviously, we don't want it too wide. So as a general rule, we say 1/3 the diameter of the canal space. So really what you're looking for is you're trying to pick the drill, the smallest drill that will remove all the gutta percha at that 2/3 length. Okay. So if you pick a drill too small, well, you're going to have a ring of gutta percha still left there, right? If you pick one too wide, you're going to unnecessarily remove too much tooth structure. So each drill that you'll have, so it comes, these little kits come in with drills in this big box. Each drill will correspond with a different post size. So just remember the last drill that you used. Once you see all the gutta percha gone, and if you're not sure, you can take a radiograph just to see there's no radio-opaque material along the sides of the walls. So once you got that to that 5 millimeter apical seal or 2/3 or at the point of curvature, then you know, okay, I've picked the right width drill. And then you're going to use that same width post to size it in, and then you may need to cut the apical end of that post so that the retentive feature sticks or is within the parameters of your crown preparation. Hopefully that makes sense. All right, let's take a break. Oh, question first. Don't take a break yet. It's okay. Yeah, so the question was, do you ever put multiple posts? So yes, you can. If you need the extra retention, let's say you got no opposing walls and you feel like that buildup is just going to fly out that way, then you can have an opposing post in a different direction. So in Vital Source in your textbook, there's a good picture of that, and we'll pull that in. So each clinical situation is different, so you'll work with your clinic faculty as to when you would want to do that. In general, one, I've never had to put 2 in, but I've seen it done. So here's a example where we talk about multiple posts. When you get real creative and from prosthodontist nerd out, you can have these like sectional post-core systems, right? So you see how these are in 2 pieces, but one needs to go in first, then the other goes in, and it kind of overlays. So you can get kind of fancy with your post systems to ensure you got adequate retention resistance form of not only your crown preparation, but also of the whole post system. Okay? So I think Dr. Jensby has a case just like this, or very similar to it. Okay? So you have like interlocking pieces. Pretty cool, right? Yeah, you guys are just thrilled. All right, let's get some excitement back into this room. Let's talk about your quiz. Yeah. We don't have in your schedule, but quiz is going to be Monday. Okay? Monday. What? Okay. So, can you do it Wednesday? No. It's going to be Monday. So you have, what, 5 quizzes? Is that what it says in the syllabus? We've taken 4? Somebody check this. Have we taken 4, right? Is that correct? We've taken 5 already, so you don't need a quiz. Oh, okay. We took 5, yeah. Here, I'll give you some good news. How about this? Monday we start prepping again. It's good news for some. And really that's our last day of sort of new information, because the remaining 2 weeks you're just prepping and provisionalizing. So we're back into kind of the regular groove of fix that you guys are more used to. Okay? So for some of you that's good news. For some of you it's going to be 2 weeks of torture. But yeah, no more of these kind of little side projects that involved endo teeth, which I know you guys love. So somebody look this up, right? How many have we taken? You've only taken 3. Yeah, and then on the syllabus it says what? 5. So I owe you guys 2 more quizzes. Okay, and then a final. So the good thing is your exam at the end of this, it's not cumulative. So last year it was cumulative. Okay. And yeah, and you guys are smarter than you guys were a few months ago, so you guys should do better, right? Yeah. Well, at least you guys know more, so which means more stuff to quiz you guys on, right? All right, you guys will do fine. We'll go over some of this stuff. All right, so that's going to be Monday, and then yeah, starting Monday we're back to the grind of prepping, provisionalizing, and I think we got 5 of those projects to do. A little update on, so I want you guys to finish the cast post exercises today. If you don't finish the projects we had yesterday, specifically the lowest priority is going to be the endodontically treated tooth with the amalgam core buildup, right? And then you do all these steps with then drill it out and then put the composite in. So you can kind of do that a little bit later on because we're going to have all those materials on hand, right? You just need a little amalgam, integrity, you already have composite you can get easily. But the post stuff, we want everybody finished so we don't have to keep having that on hand for next week, okay? So you have to get the post stuff done today. This is going to be a priority. If you don't get around to finishing that amalgam core, you can get to it next week. Okay? Cool? No? Oh, okay. They said no. Well, nothing I can do about that. All right, where do we leave off? So let's talk about this idea of ferrule. Where are we? Okay, so we talked about post width. And again, oh, just another point. Somebody asked, for your amalgam core buildups, generally that's reserved for posterior teeth. You generally don't have enough width of a pulp chamber and sort of adequate wall, just size for an amalgam core for an anterior tooth. That, and you have this big block of amalgam that's real dark, so if you use any sort of anterior crown, that's not going to work out, okay? So just kind of keep that in mind. All right, posts with, okay, so here's a clinical example that we got in clinic. This is like 2 months after I started here. So patient comes into the process clinic and said, my bridge is loose. So what are the questions you want to ask here? What other information would we want to know? Well, a couple things I want to know is, well, how long has the crown or bridge been there? You know, has it lasted you like 20, 30 years, or did you just put it in? Okay. And if we look at, so we were able to go back and retroactively look at this patient's sequence of treatment because they'd been a patient of record here. So we go back to when they first got this bridge placed, and we look at one of the teeth that is attached to the bridge, and we see how much tooth structure is left. So that tooth had undergone a root canal treatment, and then that's red line there is the level where the gum is. Okay, so I drew that in for you to see. So you can see the tooth is essentially fractured off at the gum line. Okay. And then when we take off the bridge, this is what we see. So this is the amount of natural tooth structure that was remaining before they put the posts and build up and then crown on. Okay. So obviously not a lot sticking up through the gums. So where am I going with this? Some more pictures. Okay. So that's a radiograph overlaid, right? And we measure, and there's like not even maybe a millimeter and a half, maybe at that end there. But definitely on the facial, there's no tooth structure above the gum there, right? So that's what it looks like. The post and the core buildup is still wedged inside the crown. So that's a fairly common occurrence that you'll probably see at some point in your career. Okay. So the question is, we have painted 3 different scenarios here, right? The one on the left is supposed to depict a tooth that's just cut flush at the gum line. And the one in the middle, we'll say it's a millimeter in its axial wall height. And then the one on the right is going to be about 2 millimeters that we've cut it to. And the question is, well, which scenario is more favorable if we were to put or make a cast post core and cemented it onto each of these teeth? So obviously, you would say that the one on the right is the most favorable because it has some natural tooth structure surrounding it. So one of the questions is, can we do a study that helps us determine, well, what's the minimum amount of height of tooth that we need for a restoration to be successful here, right? So we know the one on the left, that's obviously pretty compromised because the whole axial wall, that whole thing is buildup material. So we have a couple studies, well, let me just kind of illustrate that point, right? So the one on the left shows that the whole buildup, the whole axial wall was all buildup material, whereas the one on the right shows a little bit of tooth structure that the crown can hug or hold on to. And again, that question is, well, what's that minimum height of natural tooth structure that you want? And we would call that the ferrule effect. So a lot of times you'll hear the doc on the floor, they may ask you, okay, how much ferrule do you want? Or does the tooth have sufficient ferrule? What they're getting after is how tall is that axial wall, how tall is that natural tooth structure before your buildup or your core buildup starts, okay? So that's the ferrule. So it's just a definition. You can read that on your own. Here's just some more examples of the cast post-core system where you can see that the distance of your natural tooth here, this is your ferrule effect. So you would say, oh, I have 2 millimeters of ferrule, or I have 1 millimeter of ferrule, or maybe I have no ferrule. Okay? All right, so let's jump into, we'll come back to this. So we'll jump back, or we'll jump into the study. So what they did is they had 5 groups of teeth, one of them being the control that had no endodontically treated therapy. And then the others, they did a cast post core system with a crown cemented, and then varied the height of this axial wall of the natural tooth. Right? So the axial wall height of the whole complex is the same, but the amount of natural tooth structure remaining, or the ferrule, was varied. So it went from 0.5 to 2 millimeters. And we're trying to determine at what point would our system kind of be more favorable or successful. So your independent variable is your ferrule length, And the dependent variable that they measured was how many times did we have to hit this tooth for it to fail. So cyclic loading, they did 72 loading cycles per minute, and they did it at 135 degrees to the long axis. So this is to simulate, the teeth kind of coming at an angle. And then they put it in a water bath. Why do you think they did it in a water bath? Simulate the oral environment, right? So as you design these studies and read them, you kind of have to think about the method in which they designed these studies. Was it a good study? Did it account for how well does this apply to a clinical application? And what you'll also notice is this is applying to central incisors, okay? So maybe the conclusions that you would draw may be more limited as opposed if they did a study with all teeth, right, anterior and posterior. Okay, but anyways, let's just get into this. So the number of cycles, and then until failure, and then the height of the ferrule. So they found when you hit about that 1.5 millimeters of natural tooth structure, these crowns did pretty well, okay? So based on multiple studies, similar studies, so this is just one that we pulled as an example, but they all kind of give the same outcome. So we're going to say for any endodontically treated tooth that has this post system in it, you want ideally a minimum of 2 millimeters of natural tooth height to prevent it from fracturing, okay? Because if you don't, what happens is, remember the post can act as a lever arm, and it subjects the tooth to some sort of fatigue stress. So that's what this part is talking about if we go back a bit. Structures subjected to low but repeated forces, which occur in the mouth, can appear to fracture suddenly for no apparent reason. This phenomenon, also known as fatigue failure. So this occurs when a material or tissue is subjected to cyclic loading, and the idea is that you're hitting this over and over, and at some point this may result in some sort of fracture of the root, or sometimes it just breaks the cement seal, and then the whole thing becomes dislodged, okay? In either case, it's probably some sort of, or the worst case scenario, it leads to a catastrophic failure of the root. So what do you think happened in our example with our patient? Well, we would say, as we go back and sort of do this autopsy report of this failure, we would say that this tooth lacked the adequate ferrule to support that post and core system, okay? So remember we talked about restorability yesterday? One of the factors in determining restorability is, does this tooth have adequate ferrule? And remember, ferrule applies to these, all the studies we've done on ferrule have been under the scenario where it has a cast or a post and core, or basically a post space, okay? So don't confuse ferrule with just the amount of axial wall height you have for just regular resistance form, okay? So that term is frequently misused. They may have a tooth and they're looking at it and go, oh, I don't have enough ferrule. Well, the tooth's not even endodontically treated. So that term ferrule doesn't really apply in that scenario, okay? So ferrule is applying to how much tooth structure, axial wall height do you want to prevent this fatigue failure phenomenon, which often results in either a root fracture or loss of cement seal and then your post coming loose, okay? Very different from, or not very, but different from resistance form of your crown prep. So that's an important concept to remember, okay? So we're going to say we want at least 2 millimeters of ferrule for a tooth to be successfully restored that has undergone a post and core treatment, okay? Just a little bit about, yeah, question? This one here? Right. So that would explain, so if some of you guys looked at this graph closely, you would notice that at 2 millimeters, it took less cycles for it to fail, right? Okay, because there's a limit to how much, because, okay, by the time you drill lower, you see there's less bone supporting this tooth. So my theory is, why did the 2 millimeters fail at a quicker rate than the 1 millimeters? Because you have a less favorable crown to root ratio compared to this, okay? So yeah, I mean, if you want to increase ferrule, there's at some point where you remove so much bone that now this tooth is becoming mobile. Okay, and we'll talk about a couple, let's jump to it now. What are our limiting factors for how much you can lengthen that tooth in crown lengthen? Let's see if I have that slide here. Maybe I don't. Oh, here. Okay, so how much bone can you remove? Partly is going to be how much bone they started with, but the other factor you want to look at with anterior teeth is how much does the root taper, right? If you have a tooth that tapers really quickly, the more you lengthen it, the narrower the tooth gets, and the smaller your tooth is going to be, which is not very favorable. If you have a big fat root that runs all the way down, you can see that the root diameter here is very close to the root diameter here. So you haven't compromised the tooth by lengthening this tooth and gaining that ferrule. Whereas a scenario like this, as you go more apical, that tooth is becoming more and more narrow. For posterior teeth, the amount that you can gain ferrule through crown lengthening is going to be limited by your root trunk length. So let's say our bone is at this point here, and we say, okay, we want a little bit more of natural tooth structure, so let's remove a little bit of bone, so it drops down here. Well, you're still away from this furcation. Remember, it's not good to expose a furcation because it's harder to clean. Okay? So when you have a root trunk length that's short, in this example here, at some point when you crown lengthen, you're going to expose this furcation. And we would say, well, that makes it not very favorable to crown lengthen. Okay? So those are two things to consider when you're looking at whether you can gain more ferrule through crown lengthening. I don't know if that was the question you're actually asking, but you have a follow-up for that, or no? Okay. Yeah. So this just drilled deeper, but remember you have bone here, and that's a limiting factor that we have. Okay. So just a little bit about this crown to root ratio. These are from your textbooks, kind of board study questions. Ideal crown root ratio is 2 to 3. Our minimum that we would accept is a 1 to 1. Okay. Another study similar to this ferrule idea is, well, which wall of tooth structure is most critical? So here they had a complete ferrule effect around circumferentially around the whole tooth. And then this scenario, so we're looking from the occlusal view, they cut out the facial wall, they cut out the labial wall, and then the proximal. And this is just the example where it's just perfectly flat. And then they said, let's load it again and see which wall provides the best protection of that tooth. And what they found was that the lingual wall is the most critical wall, and this really applies to maxillary anterior teeth. Because let's think about the direction of force that you apply when you bite down. Where is the lower tooth is going to hit on the lingual side of that maxillary anterior tooth, and it's going to want to dislodge it, so that your lingual wall there is the wall that helps prevent that dislodgement force. Okay? So that's just another principle to remember, is that if you don't have adequate ferrule, think about the direction of force that that tooth or that crown may dislodge from. Do you have enough there? Because that's the most critical wall to have. Okay? Does that make sense? Ferrule? Well, mandibular anterior, again, the force is different, right? So I would say that this study doesn't really conclude that, right? You may have to look to another study to kind of show that that's significant. So this is specific to actually anterior teeth. And that's generally the most common situation that we lack this ferrule is, it's very common for somebody to walk in with a broken lateral or central, right? And for us, it's most significant is in a real aesthetic area, so we deal with this quite a bit. Okay. And then we end up generally saving less teeth on the mandibular anteriors because they're so small to begin with. You think about like the central or lateral mandibular incisors. If they undergo trauma or something, sometimes like all of them come out, you know. So yeah, it's easier for us to deem something unrestorable in the lower anterior because it's just you have less leeway to have a compromised tooth. All right, so we talked about this before. It's just a different picture of it, so we'll skip over it. But the idea is that which would give us a better. So this is an example. If we are lacking ferrule and we needed more tooth structure, we have two options. Remember we said crown lengthening and orthodontic extrusion. Right? We've gone over this, right? And we said that the orthodontic extrusion example is more favorable when it comes to crown to root ratio. So as we drag this tooth down and we put a crown on it, and if you did the math, you would see that this orthodontic extrusion example would give you a more favorable crown to root ratio. Okay, so here's some pictures that depict that. You basically pull the tooth up for extrusion, and now the tooth looks longer than what it started with. Alternatively, you can flap back the gums, remove the bone, and then suture it back up, and then the biologic width reestablishes, and then this tooth will look longer. So the crown has been lengthened. So just a reminder, remember when we flap open the gums, the distance from the bone to the free gingival margin is made up generally of 3 different things, each with an average of about 1 millimeter. So as we go apically, we go from the sulcus to the junction epithelium to the connective tissue. So that makes up the biologic width. We'll skip that question. The idea is when you send somebody for crown lengthening, it's important that you determine restorability and have the tooth prepared, because the specialist generally will send it to a periodontist that crown lengthens. They want to know where your final margin is going to be. So then they can do their crown, so they know exactly how much they want to crown lengthen. Because if we do the math, let's do the math together, okay? So the first layer, or the first millimeter above the bone, when everything reestablishes, is going to be our connective tissue layer, right? And then the layer above that is going to be what? Our junctional epithelium. Then we need 1 millimeter for our sulcus depth. And at this point, we would say that this is our free gingival margin. This is where we want our free gingival margin to be. And then this is assuming our margin is prepped to that. So we're equigingival right now, right? And then if you go and measure this distance from that margin to the top of that tooth structure, what's the height that we said we wanted minimally? 2 millimeters for our ferrule, right? So if you're added up, if you send them for crown lengthening and you had your margin prepped to exactly where you want to be, what's the distance that the periodontist would want to see from the bone level to the top of your natural tooth, or the top of your axial wall? You would say 5 millimeters, right? 1 for connective tissue, 1 for junctional epithelium, 1 for the sulcus, and then 2 millimeters for ferrule. So unless the periodontist knows where your definitive crown margin is going to be, they're not sure how much crown lengthening you're going to want, okay? So it's important to communicate to the other provider, because they're going to flap this open and they're just going to see this. And they're going to want to know, well, how much bone do you want me to remove? So it's easy for them if you've prepped that tooth down to your desired margin, okay? So during your caries removal, right, you may go pretty subgingivally. Well, you got to go even deeper just so you have a margin kind of established. It may be hard to get a good provisional on there, but once the periodontist has crown lengthened it, you can go back and kind of repair it and make sure it's well sealed, okay? So you may end up going pretty deep in your caries. So there's 2 reasons for that. One is you want to remove all the decay because it helps you determine the restorability of the tooth as well, okay? So important concept to remember is establish your definitive crown margin to determine restorability, and it serves as a communication tool to your specialist, or if you do it yourself, as a guide for how much you need to crown lengthen. And remember, this biologic width measurement can be variable patient to patient. So how would you determine what the biologic width measurement is in your particular patient? Right, you have to sound a bone and then do a little math, right? So you're going to measure the sulcus depth and then measure sounding the bone, okay? The other concept, and I should probably write this down and put in the slide, but for you guys, your class this year, you can write it down in your notes. You need to have a crown prepped before you send it out for crown lengthening. You don't want to prep it later, because if you think about it, the periodontist needs room to get their instruments interproximally to do crown lengthening in this area. If you have a full contour crown that hasn't been prepared yet, the interproximal surface of the crown is going to prevent them from getting any instruments interproximally. Okay, so that's the one thing that periodontists absolutely hate. Okay, because one, you haven't even established restorability, because who knows where the decay runs down to, and then two, they can't do their job. They're going to suture it back up, or they don't even start. They'll just send it back to you and say, give me a crown prep. This happens more than you think. So don't be that dentist that refers to your periodontist and then not set them up for success. Okay. So things to consider for crown lengthening, we went over this: root taper, root trunk length.